We have three talks. One is for dyslipidemia, another is that will be taken up by Dr. Manoj Gupta. Another talk is management of diabetes takeaway by Dr. Alankar Tiwari, and the third session will be online, and that will be taken up by Dr. Dhamin Jain sir. So for the first talk, I would like to invite Dr. Manoj Gupta sir. Please come over. Dr. Manoj Gupta is a renowned cardiologist in Varanasi. He is associated with the Trimurti Hospital, and he is an intervention cardiologist with a good academic interest and a very excellent person. Sir, please over to you. His topic will be dyslipidemia guideline updates.
इसको slide प्रेजेंटर्स मोड लगा प्रेजेंटर्स मोड कर Good evening, all the participants and chairpersons. Thank you, Dr. Alok, for this wonderful program and giving me opportunity to talk on this important topic, dyslipidemia. After so many great lectures, now I'll be talking about dyslipidemia. And we know that dyslipidemia is a very common problem, and we can say the most common risk factor for development of cardiovascular diseases. And in India specifically, it's very prevalent. If you look at the Indian data, there was one study published in Lancet. The prevalence of this dyslipidemia was 81%, and it was equally common in both rural and urban populations, and equally common in both male and females. And the dyslipidemia which is prevalent in Indian is slightly different, and we all know that Indian population is considered as one of the high risk ethnic group for development of future atherosclerotic cardiovascular disease. In Indian population, how it is different, because not like Western population where LDL is a common problem. Here in our population, what we see commonly is raised triglyceride, low HDL cholesterol, and also there is higher likelihood of increased lipoprotein A and high level of ApoB, which can be considered a factor contributing to more atherosclerotic burden in our population. Still, we see LDL is an independent risk factor for atherosclerotic cardiovascular disease, and as per American Association of Clinical Endocrinologists guidelines, at the age of 40 years lifetime, risk of CHD increases with high cholesterol level. And with each unit increase in LDL cholesterol, there is 21% increased risk of cardiovascular disease, 49% increased risk of all-cause mortality, and 27% increased risk of composite of CVD and mortality. Now, recently, various guidelines, they have recommendations like American guidelines, European, and there are Lipid Association of Indian guidelines also. There are very many things which are common in all guidelines. Like all guidelines, they focus or they stress upon the lifestyle modifications. all guidelines, they focus or stress on the proper risk assessment and stratification, so that we can consider the proper lipid lowering medications. So American, the guidelines, what they say, they have divided patients into two groups. One group is patient those who have established atherosclerotic cardiovascular disease. Established atherosclerotic cardiovascular disease means those who are having established CAD, patient with history of myocardial infarction, angina, patient with history of stroke, patient with history of, or patient with peripheral vascular disease, or patient with aortic aneurysm. These are the patients who have clinical atherosclerotic cardiovascular disease, and these are the patients where you need not to use any calculation. Just these are the patients where there are certain certain things, means you need to start the high intensity statins. Again, there is one group which is patient with severe hypercholesterolemia, means patient with LDL cholesterol in the higher range more than 190, patient with diabetes, and there are patient where you need to calculate the risk based on various risk scoring system. So all European and American guidelines, they stress the use of different risk scoring system for primary prevention of cardiovascular diseases. Again, in Lipid Association of India guidelines, they also have divided patients into two group, two, or we can say two group in high risk. One is category A and category B in extreme risk group. So in extreme risk group, what they mean, the patient of CAD or patient with polyvascular disease, they are kept in this particular group, where the recommendation for or target for LDL cholesterol is very low, and they say in this group of patient, LDL cholesterol should be kept to less than 30. So in European guidelines, in this high risk group, they recommend we should bring down LDL cholesterol to less than 55, but the Indian guideline, they say in patients of very high risk or extreme risk category, we should keep LDL cholesterol less than 50, and in extreme risk group B category, the LDL should be less than 30. Again, in high risk category, in all patients, the LDL cholesterol should be kept less than 70. So again, the American guideline, what they say, we should use different type of risk enhancers, or to identify those patients where we can give them maximum benefit of high intensity statin. So these are the patients who have family history of atherosclerotic cardiovascular disease, patient with having history of primary hypercholesterolemia, means LDL somewhere between 160 to 189, patient with elevated TG, patient with peripheral vascular disease, means having ankle brachial index of less than 0.9, patient with chronic inflammatory conditions. These are the patients at high risk of future cardiovascular disease. So if these like patient with rheumatoid arthritis, SLE, vasculitis, ankylosing spondylitis, so these are the patients who are at more risk of future cardiovascular events. So if these factors are present, we should give them benefit of giving high intensity statin. Again, so patients with albuminuria and patient with CKD, and these are also at high risk for future cardiovascular event. Statin remains the cornerstone of lipid lowering therapy for all primary and secondary prevention, and lowering LDL cholesterol by 1 millimole per liter, or we can say 29 milligram, can safely reduce 5-year incidence of major coronary event, revascularization, and ischemic stroke by about 1/5, and it also decreases all cause mortality. So intensive statin therapy is recommended, and this is all because of meta-analysis which has shown very effective and safety in all the trials, and it has clearly shown 15% reduction in all major vascular events. So you see all guidelines, Indian, American and European guidelines, they all recommend high intensity statin therapy in high risk population. So what is high intensity statin? Means rosuvastatin 20 to 40 milligram, atorvastatin 40 to 80 milligram. High intensity means the dose which lowers LDL cholesterol by more than 50%. Moderate intensity statin means which lower LDL cholesterol by 30 to 49%. So rosuvastatin dose between 5 to 10 or atorvastatin 10 to 20 is considered moderate intensity statin. So we can say for all secondary prevention of atherosclerotic cardiovascular disease, high intensity statin is recommended, and for primary prevention of atherosclerotic cardiovascular disease, in certain cases like patient with severe primary dyslipidemia where LDL cholesterol from the beginning is more than 190, we should give them high intensity statin. Again, diabetic patients age 40 to 75 with 10-year ASCVD risk of more than 7.5%, or diabetic patients, those who are having high risk features. So what are high risk features? Means anybody who is having diabetes of long duration, means more than 10 years of duration, presence of albuminuria, presence of low EGFR, having microvascular complications. So these are the patients at high risk of diabetic complications. So these are the patients where we should put them on high intensity statin therapy. Whenever these patients are not having these high risk features, and when uncertainty is still there, we can take help of calcium scoring. If patient is having higher coronary artery calcium score, we can put them on high dose of statin. Again, there are studies which have shown that if you put patients on high intensity statin, not only they reduce LDL cholesterol, but they also have effect on regression in atheroma also. So till now there are lot of data with atorvastatin and rosuvastatin is considered one of the most potent statin which reduces LDL cholesterol up to 55% and has shown significant reduction in hsCRP level and has shown plaque regression also. This rosuvastatin has shown favorable effectiveness in various trials. Again, there is no comparison, but recently one trial, Lodestar trial, was published last month, and where high dose of atorvastatin and rosuvastatin was compared, but there was no benefit of rosuvastatin over atorvastatin despite having slightly lower LDL cholesterol with rosuvastatin. Now again, there are patients where it's difficult with high intensity statin to achieve the target, and there comes the role of early combination therapy. So now new recommendation is we can assess the cardiovascular risk, and if patients are having baseline high LDL cholesterol level, there we can start from the very beginning with high dose statin and other non-statin combination, so that we achieve LDL cholesterol target early in these patients. So various non-statin drugs are available. One is ezetimibe, which act by inhibiting cholesterol absorption, and it reduces the amount of cholesterol delivered to the liver. And in response to this reduced cholesterol delivery, their LDL receptors are upregulated and more LDL is cleared from the blood. and it is shown in many trial. You add low dose of rosuvastatin to ezetimibe, that will result in 54% of LDL reduction compared to rosuvastatin 20, which leads to only 22% reduction. So the combination of ezetimibe and a moderate dose of rosuvastatin is more effective as far as LDL reduction is seen. So this rosuvastatin is this, and ezetimibe or atorvastatin ezetimibe, this has demonstrated a satisfactory efficacy and safety in multiple trials. Even those patients who are coming with acute coronary syndrome, now the 23 ESC guidelines, what they say in ACS patients, if patients are on a maximally tolerated statin dose or having no prior statin treatment and have LDL level which indicate that it is unlikely that target will be reached with statin therapy alone, initiating ezetimibe or any other non-statin therapy, this should be considered during the ACS hospitalization. So after risk categorization in patients of diabetes also, the CV patients with diabetes, patients, lowering of LDL cholesterol can be further intensified by adding non-statin drug. The of ezetimibe with statin is recommended in patient with diabetes and recent ACS. Again, there are other drugs available, which is bempedoic acid, which is available nowadays available and has shown in various trial that it also significantly reduces LDL cholesterol, and this can be added over ezetimibe if the LDL is not reached to the target level. So there are clear studies now seen, and this bempedoic has advantage that it also reduces CRP level as well as LDL cholesterol. So this is the clear outcome. So the combination statin with ezetimibe or bempedoic acid, this has additive effect on LDL cholesterol. Again, there is another issue is high triglyceride level, and the drug available for the high triglyceride are the fibrates drugs. And we know that raised TG is considered as a risk factor for residual or high CVD. But the CV reduction with triglyceride reduction is not very clear. But if you look at the sub-analysis of all these field trial, accord lipid trial and various meta-analysis, you can see there are certain subgroup of patients, mean those who are having triglyceride of more than 200 or low HDL, they can have some benefit if you add fibrate if you reduce their triglyceride level. Again, there is a new drug available which is icosapent ethyl, which is recently available in India also, and this drug has shown some benefit in patients those who have raised triglyceride level, and in patients of atherosclerotic cardiovascular disease, this drug has shown around 26% reduction in composite of cardiovascular outcome. So even some American guidelines also, they say if in patients those who are having raised triglyceride level and despite the lifestyle modification, patients are still having raised triglyceride and ASCVD high risk features, their icosapent ethyl may be considered. Indian guidelines also recommend that in patients those who are having very high TG from very baseline, there the fibrate and omega-3 fatty acid should be considered. But in other patients, those who are having moderately raised TG level, after lifestyle intervention, we should keep them on statin therapy. And if after statin, if TG is still raised, we can consider omega-3 fatty acid or fibrates. There are other new drugs also in the pipeline or some available also, like PCSK9 drugs, which has shown clear-cut benefit in terms of CVD reductions. So in conclusion, all individuals, all guidelines emphasize on heart healthy lifestyles. LDL reduction is cornerstone still for cardiovascular event preventions. Achieving lower LDL is associated with greater cardiovascular benefit, and sooner it is achieved, better for the patient. And one should consider all lipid lowering therapy to personalize the therapy, and lipid lowering combination therapy should be considered as standard treatment for patient at high risk of cardiovascular event. Thank you.
Now the session is open for any questions.
Hello, Dr. Manoj. I am Dr. Vikas. Am I audible?
Yes, Dr. Vikas, please go ahead. You are online, na? Please.
What is your take off with the icosapent ethyl on atrial fibrillation incidences?
Yeah, actually, in the trial of this, there was some increased risk of atrial fibrillation. There was actually this was seen as an adverse event in this trial, and there was some increased hospitalization for atrial fibrillation. You see, this was 3.1% in this icosapent ethyl arm, and it was 2.1% in placebo arm. So this was the only adverse event which was reported in this trial.
Okay. Thank you, Dr. Manoj.
Thank you, Dr. Manoj, and we will be inviting our next speaker.